Welcome everybody. This is a combined meeting of WFNS Spine Committee and Neurospine Society of Bangladesh. The Neurospine Committee, Bangladesh Neurospine Society's chairman is with us, Dr. Mohammad Hossain. Probably he wanna say something about the meeting. Mohammad?
Yes. I'm very much grateful to you to give such opportunity with a program in collaboration with WFNS, with Neurospine Society of Bangladesh. I think this will be the wonderful discussion program about the complex spine surgery in degenerative deformity. It is very much time-demanding topics. I believe the speakers will deliberate their lectures, which will be very helpful to go ahead for the management of spinal adult spinal deformity surgery. Thank you very much.
Thank you, Dr. Mohammad. Now I ask Dr. Onur Yaman to give his first talk. He will tell us the classification of adult degenerative deformity. Onur.
First of all, I'd like to thank to our dear friends from Bangladesh. We have really good friends from Bangladesh, and I'd like to thank to Max Ivy. He never lets us alone, and we have a great faculty here. La Martina Beriano will with us, and to making a classification system about adult degenerative scoliosis is really a hard topic. It's a basic topic, but we have to think about it and we have to learn it. This is a photograph from Bangladesh. We have visited Bangladesh twice. We have really good friends there. Rakibul Islam, Rasul Azam, Nabi Khan. And if you have not visited Bangladesh, you have to visit it there. And pictures from this site. We have organized a meeting last year in Istanbul, an adult degenerative scoliosis meeting. My mentor, dear Ivy, was here. He has supported us. Richard Aseker was here. And also Daniel Chopin, Frank Schwab. La Martina will also with us today, and Pedro Beriano was here and will also be here. I'd like to thank to all of them, and also another great name, Zileli, was with us. So there are lots of classification systems. The first classification system was described by Simons. He has classified the adult degenerative scoliosis in two types. The first type is has a scoliosis with minimal rotation, and the second type is a rotational deformity. And in this paper, they have recommended you can correct this deformities with distraction maneuvers and with only short instrumentation. And in the second type, you can correct them with long instrumentation and with derotation maneuvers. And the owner of the main classification system was described by Max Ivy. He has described the adult degenerative scoliosis in mainly three types. In the first group, it's de novo scoliosis. The main etiology is asymmetric disc degeneration. I will come on this topic. The second one is type 2 is progressive idiopathic scoliosis cases, and type 3 are the cases that causes different reasons because of non-spinal reasons. The first one, de novo scoliosis, is the cause of the asymmetric disc degeneration. And because of this asymmetric loads, it causes stenosis central or recess, then it causes instability, it causes deformity, and in time it progresses. And the main symptoms are caused by these reasons, and there is a cascade system here. And in type 2, there is an idiopathic scoliosis, and it progresses in time. In type 3A, these are the reasons because of the pelvic obliquity and because of the leg discrepancy. In type 3B, Ivy has described this as a metabolic bone diseases and also osteoporosis. And when we come to the Faldini classification, he has classified this in two main groups, in the stable group and unstable group. And there are subgroups here. In 2006, Schwab has classified a new system. He has divided the adult degenerative scoliosis in 5 subgroups. They described lumbar lordosis modifiers, subluxation modifier, and global balance modifier. And at the same year, SRS has described a new classification system. When we came to 2012, SRS and Schwab classification system has been published. According to this system, there are only 3 modifiers, and they have classified these groups according to the apex of the curve. The first group is the thoracic group, the second one is the lumbar, and if the patient has double curve, it's D, and if the patient doesn't have any coronal deformity, it's none. We all know the sagittal modifiers. The difference between pelvic incidence and the lumbar lordosis has to be less than 10 degrees. The global alignment has to be less than 4 centimeters. The pelvic tilt has to be less than 20 degrees. It gives us the aim of the surgery, that a proper alignment has to be given after the surgery. We all know that. Only to make a little summary about it. The pelvic incidence is a fingerprint. It doesn't change to the position. Pelvic tilt is a compensatory mechanism, and it changes according to the patient's position and also sacral slope. So we know the ideal alignment. So we have to bring the patient after the surgery in this position. But is it enough? No, it's not. A new classification or a scoring system has been described at European Spine Study Group. It's global alignment and proportion score. It's patient-tailored system. According to this, if you can get the mean values in this rates, you may have less complications after the surgery. They have described relative pelvic version. Another parameter is relative lumbar lordosis. Another parameter is lordosis distribution index. And also the relative spinopelvic alignment has been included in it. And if you sum all of them, and if you also add the age, this system shows us that if a patient has a high score, in the future you may have more complication. If you have less scores, it means you may have less complications after your surgeries. Bariano and Lamartina has been described a system, and it helps you to decide the fusion levels. The classification of Bariano and Lamartina. They have shared these groups in the first one, the balance group. The second one is imbalance group. In the first type 1, it's balanced group, and the cause of the segment is far away from the apex. So if you only operate that segment, you will choose it. It's non-apical type. The second group is the limited to apex. It's apical group. If you operate the apical segment, you will correct the spine. This is the example of a case. And in the first group, it's also balanced, but you have to fuse that coronal extended segment. So you have to fuse more than one segment. And in the fourth group, it's 4A and 4B. The patients have sagittal imbalance, and in the 4B, the patients has sagittal and also coronal imbalance. So you have to operate that patient, but you also have to correct that patient. So last guideline, we can say it, not a classification system. The European Spine Study Group has been published a new paper. According to this paper, you have to also add the coronal parameters in it. We know that in type 1, there is a coronal imbalance, and in type 2, there is a convex coronal imbalance. They have added also treatment modifiers for us. The first one is the stiffness of the main curve, the flexibility of the main curve, and also the flexibility of the lumbosacral junction. Also, the limit of the degeneration, the amount of the degeneration of the lumbosacral junction has been added in this classification system. This is the guideline they have offered in the concave group, and this is the system that they are recommending us to operate the patients in the convex group. So all the classification systems are dealing with the etiopathogenesis. They are talking about ideal alignment. They are talking about the fusion levels, but some parts are lacking this classification system, especially the age and also the comorbidities. Thank you so much for listening me. Hocam sesiniz gelmiyor.
Professor Ivy, do you wish to ask something to Onur?
No, I think Yaman showed very clearly that this whole issue about the classification is a very complex one, as you can see, you know, depending from where you go and what you want to reach. And I think the problem is that these classification systems get more and more complex, that an average spine surgeon probably cannot deal with that if he doesn't do that every day. So I think from the practical experience, you know, I will briefly talk about that when I talk about the surgical indication. I mean, it's very important to understand what is the clinical problem, because we have to be careful not to operate X-rays, but to operate patients and to operate the clinical problem of the patient. And you know, I have studied for many years this whole classification systems, and I'm still very confused. You know, there is not one system with what you can make your indications. That's the problem, because it depends for what you are looking, you know, whether you're looking for sagittal balance or whatever, or you're looking for decompression, or you're looking for stabilization and so on. So I think Yaman showed very clearly it is a very complex issue, this classification. And I'm not sure whether this classification, what just he showed at the end, this new classification, whether this is really very helpful. Maybe when you can computerize this classification, that means you can really basically use a program which gives you the different combinations. This may help, but in a practical, in a day-to-day practice, I have my doubts that you can work with this kind of classifications.
Onur, what is your preference to?
May I say something about it?
Yes.
When we have met with Max Ivy, maybe 7 or 8 years ago, I asked Ivy, why don't you made a new classification system? I told him we have to add something about it. And Ivy told me that it's not easy, and try to do a new classification system if you can do. So when I prepared this presentation, I saw that it's really a complex thing, because the etiopathogenesis is different, the natural history is different, the cause of the adult degenerative scoliosis are different. You have to put lots of things inside the new measurements in it. So you have to deal about the patient, you have to maybe use a combined classification system, because if you talk about the sagittal and coronal balance, if you do the exact measurements, exact global alignment, again the patient will fail. So there is nothing, only one classification system to use it. You have to use everything from every classification system.
Okay, Onur, and there is one question from Dr. Ercan Bal. He says that there is a classification form of Neurospine study group for surgical decision making.
Yes.
How do you find it?
I think he's talking about it has been published in 2014. About it has also been published with Lamartina and Beriano. I think he's talking about it. If he is talking about a different, he may tell us something about it.
In the meantime, Dr. Lamartina has joined us. Thank you for coming. There is another question. What about untreated congenital dislocation of spine? Although it is not the topic of us, but the question is this: untreated congenital dislocation of the spine. Onur.
Yes. What was the question? Sorry, Zileli.
The question is, what about untreated congenital dislocation of spine?
What does it? What does he mean? I couldn't get the question.
Yeah. Okay. So then this panel is focused on adult deformity or degenerative adult deformity. Patient presented at 13 years with paraplegia. Dr. Devan Asif is asking. He is meaning a kid, 13 years old, with untreated congenital dislocation of spine. Okay, we must discuss it in the case based with the films and others, I think. Huh? What Uyghur Air is asking, what is your opinion about non-harmonic spine?
I think Uyghur is asking about the Russelli classification system there, and maybe I have talked about the group in the fourth group in the Lamartina and Beriano classification. So you have to correct the spine which patients doesn't have a sagittal and coronal balance. If the patient has a sagittal balance, so you don't have to think about to correct the balance. If the patient is balanced, only we have to try to fix the problem there. If the patient has a sagittal or sagittal plus coronal imbalance, you have to solve also the balance problem there.
Okay. Thank you, Onur.
Welcome.
Thank you for a very nice overview of classifications and the complex nature of the classifications.